All right, well, welcome, guys. Thanks for those of you that are members of This Is Why, and welcome to our deep dive on this topic of evidence-based medicine, specifically the foundation. And what I really wanted to dive a little bit deeper on was this issue of this is hard. Like we talk about EBM and we teach those 5 A's and we know the components, but there's a level of difficulty in actually doing it. And so that's what I wanted to talk about a little bit more, but also raise the question of why is it so hard? Okay, so again, as a quick reminder, we have these 3 components of EBM. Most people focus their attention on that best available evidence, but we have that clinical expertise. And this is one of the areas that I think is largely being neglected. And it's really in the context of education. How we, mainly as faculty and preceptors and attendings and things like that, what are we teaching, but the way we teach it in the context that we provide the learner at their level of training, right? And then making sure that we model for them, how do you factor in patient-specific factors? What are the appropriate questions and things that we need to be asking? But again, when we're learning this 5 A's, we can teach people that. I'm going to show you here some evidence. We got lots of tools that are available that help us with components of this. Now, some people find that step 3, the appraise part, is probably a more difficult area, simply because you're interpreting statistical analysis and what does that mean, and calculating number needed to treat and all this stuff that we get buried into, which are really just helping us try to understand, what does the data mean? What do I do with this information? So I trained at Oxford in the UK, and there is a group there. It's the Center of Evidence-Based Medicine. It was actually started by one of the fathers of EBM, Dave Sackett. Dr. Sackett was mainly known for being an epidemiologist in Canada at McMaster's, which is the other powerhouse, right? I view Oxford and McMaster's as the 2 big powerhouses in the world on this topic. But Dave Sackett left Canada, went to Oxford, established the Center for Evidence-Based Medicine, and that's where I got my training. And Dr. Hennigan, who's on this particular image here, did a great blog post and a video on why is it so hard? And why is teaching it so difficult? Like I went to get a master's degree in this. And you're thinking, is it really necessary? I mean, it blew me away how much I thought I knew versus actually what I knew. And that's why I feel like the framework is so important to establish with learners, or those of you that are engaging in this topic, that you don't neglect the steps. You don't neglect the understanding of the context and the process. And that's one of the things that I felt like Oxford did really well for me, is helping me to create that framework. But they're a part of the evolution of it as well. A lot of the people involved in Cochrane reviews and some of the biggest research going on in the world are based at Oxford. And so you get to interact with these minds and these people who are experiencing the same things I talked about, the frustrations, the issues, and how do we do it better, right? Well, we have tons of resources, right? This is just a few, right? Dr. Hennigan wrote one of these. These have been around for a while. And of course, then there are educational programs, powerhouses. You've got Oxford and then the McMaster's in Canada. These 2 institutions have done tremendous amount of good work that has impacted clinical practice and clinicians, given us tools and resources, but also translates into improving public health worldwide. And so I think it's important that you recognize, there's other institutions, I'm not saying there aren't, but the point of the matter is these have been around the longest and have been probably one of the more influential groups. Now, we know, research shows, we assess on how we teach, does teaching EBM actually work? And it does. If you do it, learners can come out of a program and do like post-test analysis, and yeah, it works. It doesn't always stick. When you read a lot of this, and I'm just picking on a few papers here, but when you get down into the weeds of it and they do follow-up assessments, these folks learn principles, they learn what to do, but then over time what happens is it drops off. And they're not applying it anymore. And so that raised a very important question of why. Why did you figure it out, or did you learn it, but then did not continue to apply it? And so there was questions about that. And one of the very cool and emerging study designs are qualitative studies. That qualitative studies is kind of the personal aspect. Why? It's the question of, well, why are you doing this? How did you feel when you were on this treatment? Or why are you not doing this? It's a more subjective, unfortunately, level of information that has risk for bias. But there are very important structured ways of doing qualitative studies that make that data very valid and rigorous. They're hard to do. I have a huge amount of respect for any researcher doing qualitative research, but it's very important. But you can see here that this particular paper highlighted some of the challenges that these people quantified. Wow, there's identified a lack of teaching time within the curriculum. Sometimes these are faculty. I know that to be true. I mean, again, I was faculty in nursing and pharmacy and medicine, and I was residency program directors. And I mean, I've been involved in all those grand rounds and conferences and all these things. And despite some of that protected effort, it's still difficult to get it all in, especially if you want to teach in a manner that is consistent and provides the context of the evidence. But it becomes difficult because we have clinical practices to manage. We got paperwork to do. We got papers to publish. There's also, you see that second, this one here? Misconceptions about EBM, or evidence-based healthcare. So if you heard in the original lecture, I talked about all the EBM, XYZ terminology. And I showed you some of those definitions, if they were definitions. I mean, they were confusing. So no wonder there's misconceptions. The process of evidence-based medicine, the 5 A's for a singular patient care scenario, is not what people think of it to be or assume it to be. There's also resistance of staff. What that means is, like, sometimes people don't want to participate. It's intimidating. If you don't know what you're doing and you don't know how to critically appraise a paper, you don't know how to interpret literature, it can be intimidating. And so there can be a cognitive dissonance where there's a rejection of it. There's a resistance to it. I don't want to do that. That's for people who are very academic. That's not us. I don't want to be an academician. Well, you're not. It's not about being an academician. You're supposed to be. We're all, as licensed healthcare providers in nursing, pharmacy, and medicine, it doesn't matter. We're supposed to all be participating in lifelong learning. And if you look at EBM as a discipline, it is taught in nursing, in pharmacy, and medicine. So it's not even even though it started out by the EBM working group in a medical residency program, it's gone way past that, right? It's pretty much permeated all the disciplines. So when you think about that, we're all learning it. It's part of our curriculum. When I was in nursing school, pharmacy school, and medical school, and in residency, I got taught this subject. And despite all of that, because I went to Oxford after medical school, So I'd already had pharmacy and nursing, medicine. You'd think I'd know it. And I was blown away by how much I still didn't know and how I didn't fully grasp what these terms mean, because we don't talk about it and it wasn't provided to me. I'm not saying that my training was bad or there was limitations, lack of time, right? Some resistance. There was a lack of confidence, negative role modeling. What does that mean? Well, think about, the terminology of people being pimped on rounds or in clinic or in the classroom or in conference. They just call on you. It's like you feel like you're being put in the middle of the center of the crowd and you're just being beat up, right? You're just totally wide open to attack. Those negative environments where people are pimped and the intimidation that it creates and the anxiety, that's not a positive learning environment. And if the person likely that's doing that is probably hiding something, to be honest with you, right? They're probably trying to put on a persona that they don't necessarily want people to ask them too many questions or think they don't know something. And so we put this mirror, this, kind of image up of what we want them to think and assume about us. And so that's not a positive. I don't know everything. I flat out tell students that and residents. Sometimes I say, let's just look it up. I remember reading about that. I don't remember. Let's look it up. That's the way we should approach it. When we ask questions, it should be in the intended desire to identify knowledge gaps so that we can fill it. I know for myself, I learned more when somebody exposed what I didn't know. I don't know what I don't know unless you expose it, right? I mean, how am I going to fill in the gap? And I remember parts of my training, especially because I had already had a clinical experience and I had a lot of knowledge, I'd already done research, I'd already published. A lot of times my attendings and some of the faculty would dismiss me as like, oh, you already know this, we don't need to talk about it. Well, wait a minute, no. How do you know I don't? I mean, yes, I might know some of the things you know, but that doesn't mean I know everything. And so I didn't like that. I actually stopped telling people what I did or my background because I wanted them to treat me as if they didn't know who I was or my background so that I could learn more. Because I cannot identify what I don't know unless you expose it to me. And I loved being exposed as long as it was in a healthy educational environment, right? And so that's the model that I create. But you can see here it makes it difficult, especially when people start quoting literature and data and papers. Okay, so, teaching EBM works, but it's not implemented in practice. That's what the overall pattern of the literature shows. It's hard, like Dr. Hennigan from Oxford said. Despite knowing the process pretty well, despite having good books that are published, there's also misconceptions. I think there's some confusion about EBM terminology and how it all works. The other thing that's interesting is that the quality of care is not proportional to the current technology that we have. Think about all the availability, especially now with online resources and apps and all these things and AI and the resources that we have at our fingertips in seconds. You would think that we would be making more evidence-based decisions at the bedside. But again, you have to train in that model. You have to learn that skill set. And well, here's the problem. Depending on how old you are, right? I mean, many of us, I did nursing school, pharmacy school, medical school. I think I've been in school, 20 some odd years after high school. So to go back and learn something again or fill in major gaps, quite honestly, feels disheartening or deflating. And I think that's true for most people. Even if you only did one degree, still, most physicians are going to do 7 to 8 years of medical training beyond their undergraduate degree. Same thing with many of pharmacy. depending on what you do as a physician assistant or nursing or whatever, right? There's some programs out there, but many people go through years of training beyond high school, and you get to this point and then you arrive and someone's going to tell you, you still don't know something? You still lack the proper context? So go back and try to read all that. I mean, I barely made it through, right? Felt like a fire hydrant of information. I mean, I think we can all relate to that. If you go back to the early days when you were trying to absorb the information and you were trying to make sense of it, I mean, for someone to take you deeper into the evidence, you're like, dear God, I just need to know this right now. I'm drowning, right? And so that's why people rely on guidelines, summaries, encyclopedia type of tools. Not diminishing that. But the reality is it doesn't necessarily mean you understand the proper application of evidence and how to interpret that, okay? And so is it possible that there's something still missing in what we're doing today for the current generation and the next generation to come, right? Are we really wanting to just be complacent, passive learners that are told what to do, or potentially being taken over by AI-generated decision making, where if you don't have the knowledge, how do you know the machine is wrong? Right? Who's programming that? Where is it at? So do we want to develop evidence-based practitioners and experts or not? And what does that look like? Right? So we need to be able to recognize the difference between EBM, evidence-based healthcare, and how does all of this fit? Well, you guys heard in the lecture that I did in the topic review on EBM, this first step, that evidence-based healthcare is the umbrella. And then we have evidence-based practice and we have evidence-based medicine, which are the individual decisions that then allow, if you break it down further, there are people inside there that are practitioners, experts, and then we have all that, if it works like it's supposed to, and everybody does it, we will see an improvement in typically medical outcomes, okay? But what is the state of current medical education? What does it look like? Okay, so think of the healthcare professional. Again, nursing, pharmacy, medicine. We're all being taught this subject, right? What are the things that influence that? Well, we have core medical knowledge, the facts. What is the disease? What is the pathophysiology? How is it different from the normal anatomy and physiology? How these patients present? What are the names of the drugs? Brand names, generic name, what drug class? I mean, those are facts. That's core knowledge. And that's where we spend most of our time, especially in training, isn't it? We have to acquire it somehow. I'm not minimizing that. It's important. But remember, it's not by itself. We have to go get medical information from other resources. That could be textbooks. It can be online services. It can be conferences, meetings, getting into the literature, reading it. Then you have to go and start applying it, practicing. We call it practicing, right? Because at the beginning, you don't know what you're doing, right? You need to be under the mentorship of somebody, a preceptor, an attending. But you've got to get your hands wet. Got to get in there and see the patients. Put your hands on that environment. See it, what happens when you do apply a decision and the outcome that is generated. So those are the three most common inputs that most of us experience. Now it looks a little different. Residency, no residency, certification programs, no certification programs, all these things. But that's fundamentally what it looks like. But when you go and you think of, okay, this evidence-based medicine and these principles that the EBM working group was talking about and published back in 1992 that created this paradigm shift, and I believe that's true. I think it was a paradigm shift in the way we thought and challenged ourselves and why we do what we do. But you got to blend these two things. So what does that look like? So is there a missing link, right? So I like to think of what I try to do, even at This Is Why, but even the way I taught when I was faculty and when I still precept and attending and I got students or residents, right? What what does that look like? So you have a core curriculum of knowledge. You have medical educators, people like me, right? But I'm still a learner too. I do not know everything. I don't pretend to know everything. I'm sure that many of you will provide me comments and feedback and say things, and I'll learn from that. That's good. We need to do that. I'm not afraid of that, right? I know my limitations, and I know I have gaps, because as I've gone through all that training, I've learned out how much I still don't know, right? So I want to learn more. But what does that look like, again, kind of coming back to this framework, right? I'm not saying this is a framework I made, because there isn't one with all these terms that we're using. Again, I'm trying to make sense of it, okay? To make it integrated, cohesive, to wrap our minds about where am I in this piece and where are you in this, no matter where you are. If you're a student, a resident, or you're a clinician, you have 20, 30 years of experience as well, right? But there's something missing. And in my personal opinion, in my assessment, throughout all of my training, as great at places that I went, I found it that I was not probably getting some of the education in the proper context of the evidence. And what I mean by that is people are taught things, I hear people say things and it's overgeneralized sometimes, or it gets twisted a little bit because somebody else taught it to them and they heard it this way, and they just keep propagating it, and no one ever goes back to the actual paper or the literature and go, that's not what the paper says. How did we get to this? You know, stories change as they get disseminated and shared, and people adjust it, or they have their own bias. I mean, I have my own biases. I know that, and I will tell you that. I'm fairly upfront as you listen to some topics that I teach on. I will tell you up front, I don't like this class of drugs, or I find this an issue. I don't understand it. I don't know why people give it so much attention, whatever. I'm not afraid of that. And that's okay. I'm entitled to my opinion just like you are. All right? But it should be evidence-based. And so there's this concept of evidence-based medical education, where we're not just talking about EBM, the 5 A's, what to do, how to do a journal club, but that we're learning it's integrated within the other core content, so that when we learn something about a disease or a treatment, if we weave in the evidence in a way that is understandable, it comes to life. Why do I give the doses that I give in this situation? Because that's the way it was studied. Oh, okay. So it's a protocol that was approved and it was studied, and that's where the mortality benefit. So you have to use it that way. And in some medical conditions like heart failure and things, there are target doses that we achieve because we want to maximize the benefit. Well, where'd that come from? The evidence. Now, do you need to quote every paper and stand there like you got, this journal and this volume? And no, that's not what this is about. You don't have to know the journal and the year and the name or the acronym associated always with it. It helps. But yeah, I just know where to go get it. But here's what that study said. This is what this study found. This is why I do what I do and why I'm recommending this treatment to you. And I may say that to one colleague to another, but I'm also talking to the patient. Here's the options you have, patient A. There's pros and there's cons. I'm going to present to you both of them because those are the two options you have. I participate in shared decision making, and most people feel not only appreciative but empowered, like they are taking some degree of ownership in their own care. But it comes back to incorporating that strategically into the education that we're doing. So what does that look like? Right? So now I'm going to make a bigger sort of Venn diagram, if you will, and the components. Just follow me for a second. So you see here that we have something called, I call it evidence-based medical education. It's education in the context of evidence. Not every single paper under the sun, but in the context of the best available evidence. right? So that's an EBME kind of teaching model. It's the one I use, okay? There's the learner's knowledge. I need to know where you're at. I'm not going to teach the same thing to someone who's a fellow as a medical student. Now, I might introduce them to the topic at a different level of difficulty, but the degree of detail that I get into or the expected amount of knowledge that you have that I'm going to now build on is going to be different if you're a medical student or a pharmacy student or a resident or a fellow. So it should be learner-specific knowledge assessments. That's what pimping is kind of supposed to be, right? But it should be in a positive, healthy environment. Then you have EBM, right? Connecting. It's a bridge. It's holding on to both of those, okay? EBM is the 5 A's and doing it well, making sure that you understand, ask, acquire, assess, apply, and then, sorry, you ask, you go and acquire the information, you appraise it, right? Then you apply it, and then you do your own assessment of your own clinical practice, right? And then we have the patient factors, which again, we've already talked about before, but you want to incorporate all of those things. And so inside that, if you do all those and they bridge and gap and touch each other in a curriculum, an entire program, or a topic review or whatever, then that's when people start to transition from being a practitioner to being someone who's an expert, because they're doing the 5 A's. They know how to read it. They can teach themselves something. They're a lifelong learner in its original intent. Okay? Now, this is the traditional Venn diagram, and this is my diagram. This is the way that it actually probably should look, but doesn't. Okay? I'm not trying to be discouragement. I'm trying to not be critical of the system, but I'm challenging myself, like I've been doing for years, which is why I continue to go on through so much training. I wanted to learn, I wanted to understand, I wanted to integrate, but I started to observe holes and problems, right? And so we've got to start challenging and continuously assessing our own processes of how we train and teach the current and next generation of providers. And so how do you blend in an educational model that builds strategically that context of evidence? It's not easy because you have to know it. You have to know where the evidence is, what it is, and what it says, and then you have to have the core knowledge to bring it all together. Well, unless you train that way, or you were taught that way, and you're modeled that way, and you're doing it, that's hard. And that's why if you look at the evidence on EBM and its application, implementation, its acceptance, its continuity in practice is not there because it's too difficult sometimes. It seems overwhelming and you're like, so Dr. Busti, you're basically presenting a model that's impossible. No, it's not impossible. We have to start somewhere. And that's in many reasons why this is why exist. Because when we understand why we do something the way we do, then it makes the how relevant. How is the clinical decision making? How do I manage this patient? How do I treat this medical condition properly for this patient that may look different from that patient to this patient? I have to start somewhere. And I just take small nuggets. And over time, my knowledge base starts to grow and it expands. And so I have maybe, this ideal vision for what I think healthcare can do, but I can tell you this, we spend more money per capita than most countries in the entire world that look like us, and we have some of the worst outcomes. Why? We have these fancy buildings, all this technology, we have access to all this stuff on the internet and on apps and our phones and AI and all this stuff. And yet we have some of the worst outcomes. I mean, we can't blame the patient. We can't blame the pharmaceutical company and the cost of drugs. I mean, it's not just as easy as that. There is an element to what we do, the decisions that we make, and how it impacts a patient and the system. And we have to begin equipping ourselves to do that. And so when you bring all these together, and at the very center is the patient, in my personal experience, right, even though it seems to be difficult, slightly impractical, or overwhelming, I guess, it's doable. I've seen patient outcomes significantly improve, and patients feeling better, happier, empowered, positive interactions with the healthcare system. That's why we're here, why we're doing it. We went in to help people and to contribute to overall public health. So you can't just read data, read journals, have a bunch of letters behind your name, have all these degrees on the wall, tell people what to do, and think it's just all going to work. We have to engage as a member of the healthcare team. That means, as a physician, you need to work with your colleagues in nursing and pharmacy and occupational therapy, your PAs, even spiritual support, all of them. Everybody's a member of the healthcare team in a system. Even our pharmaceutical companies and our colleagues in the pharmaceutical industry, bringing new drugs to market. We need to work with them. We need to have that shared process of discussing things back and forth. I understand the history, trust me. I understand some of the but they are in a business. Yes, it costs a lot of money to bring a drug to market. But so is a hospital's in business. It has to stay afloat, it has to open the doors. But we all have to stop viewing ourselves as separate entities and sort of antagonistic to each other, and view what strengths and do we bring together that we, when leveraged appropriately, creates this positive working environment that progresses the advancement of medical care and improves patient lives. And that is ultimately why we do what we do. Now, you may be saying, okay, Busti, I'm kind of sold, although I feel a little overwhelmed. I've already had a seizure. I'm starting to drink a beer or whatever, right? I don't know that I can do all this, but I understand what you're saying. What does it look like? You said you do this or you teach this, and like, what does it look like? So let me give you a sample, something so simple, so basic that we do. I mean, I could probably ask most healthcare providers, even specialists who don't do it, and they mostly know the answer to this in a very basic level, okay? And so let's do an example of this. What is the question that matters most, like that we see all the time? Well, we know, first of all, a drug called aspirin has been around for a long time, right? It's one of those grandfather drugs into the process. I don't know if it would get approved today. It certainly would have to have a very special study that would, help to get it approved in the way we do it today. And there is a study, right? We're going to talk about it. It's ISIS 2. But why, stop and think about this. Why do we give patients with acute myocardial infarction aspirin? Just stop and just ask yourself, do I know the answer to that? Like, I'm talking really, and I'm not talking about the answer the guidelines tell me to. That's not an answer. It is. It's not the answer that's like you should as a clinician, especially if you're a licensed provider, should be able to articulate why you give somebody aspirin or recommend it in acute myocardial infarction based off of the evidence and in the context of the evidence. Because there's confusion about this, and I see it happening all the time, okay? But we give patients aspirin because doing so provides a 23% reduction in vascular-related mortality, as well as the risk of reinfarction, non-fatal stroke, without increasing the risk of bleeding. And that includes cerebral hemorrhage. Okay? So it's not all-cause mortality. It's 23% reduction in vascular-related mortality while also reducing the risk of having another heart attack, having a fatal stroke, a non-fatal stroke, and without causing significant bleeding. That is why we give it. Well, what's it based off of? Mainly the ISIS-2 trial, which was a international, multi-center, prospective, randomized, placebo-controlled trial of 17,000 patients. That's the study. That sounds like a good study design, does it? Do we need to go into all the details, like it was a 2x2 group, and they did streptokinase? No, we don't need to get into all that. But there is clear evidence, and I just articulated what it means. Now, it was followed up. What does the pattern of evidence also show? So that's what systematic reviews are very helpful at doing. And the BMJ published a systematic review on this subject, and it showed also a 25% reduction in vascular-related mortality. So it's vascular-related mortality, not all-cause mortality. A lot of people tell me that. It's vascular-related mortality. And guess what? It's also in the context of secondary prevention, not primary. I can't tell you how many patients I see on aspirin. I go, why are you taking that? Have you ever had a stent? No. Have you ever had a heart attack? No. Have you ever had a stroke? No. Have you ever had peripheral arterial disease? No. I said, well, why are you taking that? Well, my doctor told me to, just in case. Just in case. Or because I had high blood pressure, so I should be on aspirin. No. That's not what the evidence says. There has been large debates about the use of aspirin in primary prevention of cardiovascular disease, vascular-related disease. The evidence is in patients who are actively either having one or just had an event. And that's why it's vascular-related mortality and not all cause, and it's not for primary prevention. That's not the way the data panned out. Okay? So that's a good example. It's probably one of the most easy examples and relevant that most people, even lay people, at some level kind of could guess that. Like, I give aspirin to someone who has a heart attack? Because they do it, right? We've done so well at educating people in the public about the use of aspirin that sometimes it gets exaggerated, it gets pushed across its boundaries of what it was originally studied for. Anyway, I hope that you found that to be relevant, but also a deeper dive into this subject of why evidence-based medicine in the context of what we do every day matters. That is why we're here, guys, to help medical professionals like you understand the why so that you can master the how. Because when we do understand the why, you don't just are practicing medicine, nursing, pharmacy. Remember, you are transforming it. So thank you for joining us, and we'll see you next time.